Good evening, esteemed professors, senior colleagues, and resident doctors. I would like to thank OSN and NIPOS for the opportunity to give this presentation on ophthalmic manifestations of neurofibromatosis and its management. I also want to appreciate my husband, my children, and members of Department of Ophthalmology, UBTH, Benin, for their support, even as I prepared for this presentation. I'm going to be taking the presentation under this outline. And we are going to start with neurofibromatosis, which is a genetic disease of the nervous system that affects the development and growth of the neural tissue. It affects the skin, the nervous system, the eyes, and other organs. The pattern of inheritance is autosomal dominant with irregular penetrance and variable expressivity. It belongs to the phacomatosis, which is a group of disorders characterized by hematomas of the skin, eye, and central nervous system. The collective name was given by Van der Hoef in 1932. There are other diseases under this group, which are outlined as we can see. Ade Miluyi et al. In 1988 studied 14 children with neurofibromatosis 1 in Lutz and reported no ocular finding. Onunu et al. In 2002 studied 26 patients, representing 0.54% of new patients attending the dermatology clinic. 50% of these patients had iris nevi. Odebode et al. In 2005 reported plexiform neurofibroma in 8 patients in Ilorin, while Iandati et al. In 2009 reported plexiform neurofibroma in 6 patients in Maiduguri. There are 4 recognized forms of neurofibromatosis. Von Reckling-Hansen's neurofibromatosis, also known as peripheral neurofibromatosis, bilateral acoustic neurofibromatosis, known as the type 2 or central neurofibromatosis, segmental neurofibromatosis, and cutaneous neurofibromatosis. Based on Riccardi's classification, they have been classified from type 1 to type 5. Type 1 affects the skin and peripheral nervous system, and is as a result of mutation of the NF1 gene located on the long arm of chromosome 17, which is a tumor suppressor gene. While type 2 is characterized by central nervous system tumors and posterior subcapsular cataract, and is due to mutation on the long arm of chromosome 22. Neurofibromatosis 1 is also known as von Reckling-Hansen syndrome, and is the most common form that accounts for about 90% of cases, with a global incidence of 1 in 2,500 to 3,000 individuals. It is inherited in an autosomal dominant pattern, and about 50% represent a new mutation, which means that 50% is sporadic. Inheritance is independent of ethnicity, race, and gender. There's a diagnostic criteria for type 1, and it is based on the National Institute of Health Consensus Development Conference, an individual that has 2 or more of the following features, which include 6 or more café au lait spots, axillary or inguinal freckles, leash nodules, neurofibromas, either 2 neurofibromas or 1 plexiform neurofibroma, optic nerve glioma, distinctive bony lesions, such as osteosarcoma, first-degree family relative with type 1 neurofibromatosis. The ocular features of type 1 neurofibromatosis is outlined as in this slide. Palpebral neurofibroma, which occurs in the eyelid, is a benign tumor of the peripheral nerves. It arises from cells that form and support the nerve sheath, and is composed of Schwann cells, fibroblasts, perineural cells, and mast cells. There are 2 types, the nodular and the plexiform neurofibroma. The nodular neurofibroma is solitary or multifocal, is painless, and a smooth surface, well-defined mass, and can cause mechanical ptosis. While the plexiform neurofibroma tends to originate from the orbital branches of the trigeminal nerve. It's a diffuse thickening of the eyelid, which produces the typical sinusoidal S-shaped curvature of the eyelid. The tumor is soft and feels like a bag of worms. The glaucoma tends to occur on the affected site in a significant proportion of these patients. Plexiform neurofibromas of the orbit are associated with congenital absence of the sphenoid wing, as seen in this picture, or enlargement of the sella turcica. This leads to intracranial pulsation, which can be transmitted to the orbit, causing pulsatile proptosis, or more rarely, pulsatile enophthalmos. There is orbital involvement in these patients, and this can lead to proptosis or diplopia. This can be caused either by orbital tumors, such as optic nerve glioma, optic nerve sheath meningioma, or orbital neurofibroma, or by a defect in one of the orbital bones, as we just mentioned previously, allowing for herniation of intracranial tissue into the orbit. These patients could also have prominent corneal nerves, which are thickening and neurofibroma of the corneal nerves. They could have glaucoma, which occurs in 1 in 300 patients, and these patients, the patients that have orbitofacial involvement have been found to have higher rates of glaucoma. Those with palpebral plexiform neurofibroma have been found to have ipsilateral globe enlargement that could actually extend to up to 36 millimeters in the axial length. You can see that this child has left plexiform neurofibroma, and the ipsilateral left eye is also glaucomatous. They could also have congenital ectropion UV. This has been linked to refractory glaucoma because of endothelialization of the anterior chamber angle. As you can see, the growth of this ectropion UV is gradual, and it grows to completely cover the anterior surface of the iris and involve the angle. They also have leash nodules, which are present in 95% of cases. These are brown to yellow nodules and appear early in childhood. They tend to be bilateral. And on slit lamp examination, they are seen as round elevated nodules within the iris, measuring 2 to 3 millimeters, and are said to be aggregates of melanocytes. These are the nodules. They could have choroidal nevus, which is a flat pigmented tumor of the choroid that is brown to gray in color, oval or circular in shape, with indistinct margin, tend to be post-equatorial in location, and they have an extremely low risk of malignant transformation. But if there is clinically detected growth, it is better to suspect malignancy. This picture shows the nevus. They could have choroidal neurofibroma, which is a diffuse thickening of the choroid due to increased number of neurofibromatous and melanocytic elements, which can be seen in this picture. These are the diffuse areas of thickening of the choroid, seen in this red-free picture. And also in the OCT, you can see the thickening of the choroid. These patients can also have choroidal melanoma, which is a large pigmented tumor and presents with reduction in vision depending on the stage at which the patient is found. There's a higher incidence in these patients that have neurofibromatosis, and fluorescein angiography will show a filling of the vessels in the choroidal mass, as well as a solid dome-shaped mass on B-scan. Here's the picture showing the melanoma. Retinal astrocytic hamartoma is a benign retinal tumor composed of glial cells, predominantly astrocytes. It's found in the nerve fiber layer, and they tend to be grayish in color and may extend to the peripheral retina and cause neovascular glaucoma and retinal detachment. This is the hamartoma here. Combined hamartoma of the retina and retinal pigment epithelium could occur, and these are benign tumors that may cause significant vision loss depending on location. Usually, they are solitary lesions, tend to be unilateral. They could be located at the optic disc or posterior pole, and they may progress with time. As they progress, they may be slightly elevated with varying amounts of pigmentation and vascular tortuosity. They could even have epiretinal membrane, which we can see here. An epiretinal membrane is a thin scar formed on the surface of the macula. They could also have retinal capillary hemangioma, which is a vascular hamartoma of the retina. Appears tortuous with large diameter capillaries lined by normal endothelium. And these are composed of a proliferation of endothelial and stromal glial cells. So we have the increased tortuous vessels seen here on the fundus photograph as well as on the fluorescein photograph. Optic nerve glioma can be found in these patients, and they are slow-growing pilocytic astrocytoma, which affects children. It's present in about 15 to 30% of patients, and they have slowly progressive visual loss in about 35 to 50%, followed later by proptosis. Proptosis is non-axial with temporal or inferior dystopia. Optic nerve glioma tends to occur early in neurofibromatosis 1 and tends to be non-progressive. But when they begin to enlarge rapidly, it is due predominantly to an increase in the mucinous component of the tumor rather than true neoplasia. Initially, the optic nerve head is swollen and subsequently becomes atrophic. The intracranial spread could occur to the chiasma and the hypothalamus. And on histology, we find spindle-shaped pilocytic hair-like astrocytes and glial filaments. This picture shows the optic disc edema, okay, as a result of interruption of axoplasmic transport due to the nerve compression. And this is the subsequent optic atrophy that can occur. Also, they could also have opticociliary shunt, which are pre-existing vascular channels which open up in the presence of obstruction. The same thing, they could also have central retinal vein occlusion. On MRI, there's enlargement of the optic nerve with enhancement of the central substance of the nerve. And then if there's intracranial spread, MRI will show it. CT scan will show a fusiform enlargement of the optic nerve with a clear-cut margin produced by the intact dural sheath. This is a picture of the MRI with the central enhancement of the nerve. In neurofibromatosis 1, MRI with or without contrast of the brain and orbits is important to confirm the diagnosis and to monitor progression. It is recommended to avoid CT scan if possible because of radiation and the risk of malignant transformation of neurofibroma. They also need to have serial MRI, which will be tailored according to the patient's needs and disease progression. When managing these patients with type 1, we need multidisciplinary approach, which includes the pediatric ophthalmologist, the neuro-ophthalmologist, the oculoplastic surgeon, the neuro-oncologist, and the geneticist. Genetic counseling is very important for these patients, and every family member of these patients need to be screened to rule out neurofibromatosis 1. Children will need regular ophthalmological examinations every 6 months until the age of visual maturation at 7 years to detect and treat amblyopia, glaucoma, or strabismus. Early diagnosis and treatment of ocular problems is important, And if they have palpebral neurofibroma, they would need surgical debulking. Indications for surgery include cosmesis, decreased vision, progressive involvement of a vital structure, and functional deficits. Otherwise, it's better to leave because of the high recurrence of this tumor. Glaucoma can be treated using intraocular pressure lowering drugs, and if severe and not being able, controlled by these drugs, surgery is an option, which could be goniotomy, trabeculectomy, trabeculotomy, and tube shunt, depending on how severe the case is. Patients with leech nodules, congenital hypertrophy of the RPE, and retinal astrocytic hematoma can be observed. In the presence of choroidal melanoma, plaque radiotherapy, resection, or enucleation is done depending on the size of the tumor. For those that have retinal capillary hemangioma, if anteriorly located, will benefit from cryotherapy. If more posteriorly, that is posterior to the equator, they will benefit more from laser photocoagulation. They could also have photodynamic therapy, plaque radiotherapy to control exudative changes. For patients with neurofibromatosis 2, is a multi-system disorder with an incidence of 1 in 25 live births with nearly 100% penetrance by 60 years of age. The average age of onset is approximately 20 years or more, and is associated with reduced lifespan when they have CNS tumors that present at a young age and are multiple. Features include CNS tumors, which are bilateral vestibular schwannomas, spinal cord schwannoma, meningioma, and glioma, as well as juvenile posterior subcapsular cataract. Diagnostic criteria for these patients include bilateral 8 cranial nerve tumors confirmed by MRI or CT, or unilateral 8 cranial nerve tumor plus a first-degree relative with type 2 neurofibromatosis. Another way to make a diagnosis is if the patient has 2 of any of the following: meningioma, glioma, schwannoma, juvenile posterior subcapsular lens opacity, plus a first-degree relative with type 2 neurofibromatosis. Ocular features in type 2 include posterior subcapsular cataract, epiretinal membrane, combined hematoma of the retina and retinal pigment epithelium, as well as optic nerve sheath meningioma. Cataract occurs in 60 to 80% of patients. Opacities can be the first sign to suggest diagnosis in childhood. And when they have cataract, it tends to be posterior subcapsular or cortical cataract. That is it. Epiretinal membrane is a condition where a very thin layer of scar tissue forms on the surface of the retina at the area of the macula. And when it begins to contract, it can form macular pucker. And when there's vitreous traction, when there's vitreous pool on the macula, it can cause vitreomacular traction syndrome or cellophane maculopathy. They could also have combined hematoma of the retina and retinal pigment epithelium, as seen in this picture. Optic nerve sheath meningioma, in these patients they present with proptosis and loss of vision. An MRI will show thickening and enhancement around the optic nerve, which is known as the tram track appearance. Management of these patients depends on what they have. If there is cataract, extraction. If it's optic nerve sheath meningioma, surgery. And if excision is incomplete, postoperative radiotherapy is recommended. For those that have epiretinal membrane, they will benefit from vitrectomy and peeling of the membrane. In conclusion, neurofibromatosis can affect the eye and ocular agnesia in various ways. It is therefore important to recognize ocular involvement in such patients, as this will aid earlier diagnosis of treatable conditions which can be vision threatening. Thank you for listening. These are my references.